The TMJ-TMD conundrum is real and has been puzzling the dental and medical professions for decades. This is the TMJ-TMD Demystified Podcast with Dr. Tony Urbanek, where we'll connect the dots between TMD symptoms and the actual cause. We'll tackle common TMD misconceptions and educate you, the practitioner, about a simple, tested, and proven TMD solution that has already provided relief to thousands of patients, while helping practitioners build an additional source of income free from insurance control. Welcome to this episode of the TMJ-TMD Demystified Podcast.
It's Tuesday, and we are gathered for the next episode of TMD Demystified. I am Tony Urbanek. If you're new to the podcast, welcome. If you follow the podcasts along, this is podcast episode number 179. I usually try to record these every Tuesday. They parallel a blog that I write every Sunday. The blog is directed to patients. The episodes in the podcast are directed to professionals, primarily dentists, but they usually parallel in topic and description and purpose. So today's title, I think, is, again, very interesting title. I hope you find the rest of it interesting as we roll it out. Very appropriate, for sure. It comes via my associate in the practice who came to me and said, we had a patient recently that was a diagnostic problem, and I had to ask your help in it, and I think that it would be good if you could put together a episode about differential diagnosis. So today's title is When You Shouldn't Treat TMD Symptoms, when you should not treat TMD symptoms. And hopefully you can see the relationship between that title and differential diagnosis. So differential diagnosis is not something that is foreign to the dental establishment, the dental profession. It is a little more complicated in the medical profession because they have more access to physical and technical tests that have been worked out to help in the differential diagnosis between diseases. But in the case of TMD, again, fortunately, it's all pretty simple. It's all pretty simple and not complicated. But we had had a patient just recently, and I think that if you treat TMD to any degree and of any level of interest, you're going to run into these patients of one variety or another. So let me paint the little history on this particular patient. Hopefully you'll find it interesting. My associate did a consultation with a roughly, it's probably 70-year-old female and her husband. Female's primary chief complaint was she couldn't open her mouth, couldn't chew, couldn't open her mouth. And he had really went into the depth of the consultation, but before it was over, he decided he ought to bring me into it. And we might talk about why he thought in a little bit, but he stepped into my office. He said, "Tony, can you come down the hall and see this patient along with me? Because I think it's a little bit outside my arena, my wheelhouse." So I said, "Sure." So I went in and introduced myself and began gathering information. The information was pretty simple to gather. First of all, I clarified that this patient couldn't open beyond one finger breadth and had been that way for roughly about 6 months. She had come to our office, not on referral from another doctor, but out of Google, and found out that, Googled doctors who help people who can't open their mouth, I guess, and came into our office. And chief complaint was, I can't chew and I can't open very well. And went into the medical history and right off the bat, learned that this patient had had surgery 3 years prior for an oral cancer here in Nashville at Vanderbilt. I actually got the name of the surgeon. I know the surgeon personally. And patient had had a radical neck done along with her oral cancer surgery. I didn't have the operative note or the discharge summary or anything available to me, but I gathered from the patient and the husband who was at the room the general information that I needed about this. Examination of the x-ray showed evidence of temporomandibular joint damage. She had significant degenerative joint changes within the temporomandibular joint. Her joints were hot. They were painful when pressed on, which is certainly an indication that there was chronic inflammation within the joint. The x-ray was positive for long-term chronic inflammation. And her two symptoms that she presented with are certainly symptoms associated with temporomandibular joint disease. However, she did have a history of cancer, but on further investigation, claimed that after her cancer surgery, she was able to open fully. She was able to open fully, and by her history, the decrease in ability to open did not happen gradually, but it was all of a sudden, which again would be another indicator that it would be a disc problem. A sudden decrease in ability to open is certainly evidence of a dislocated disc. So there's a lot of information here leading to a temporomandibular joint issue, a temporomandibular joint problem. But on further delving into the history, even though the patient told me her inability to open came all of a sudden and only a short time, less than a month or actually, I think she said 3 weeks prior, she was able to open fully. I didn't necessarily, it isn't the patient was lying to me, but I didn't believe her history was accurate. She was an older patient. Her husband was an older patient. I sensed that she didn't pay much attention. Neither of them paid much attention to their medical care. They had not seen the surgeon who performed the surgery for a couple of years, which was a little, very unusual in my knowledge and my experience, because when performing that level of cancer surgery to the head and neck, it's appropriate to follow patients along looking for recurrence. So to make a not too long story short, I did a little bit more physical examination. I examined the patient a little bit in more detail about pain in and around the coronoid processes. One other thing that I did feel was that there seemed to be some exposed bone up around the right coronoid process, exposed bone. It was hard to get my little finger up the ramus to try to touch the tip of the coronoid process. But again, it was painful to touch the tip, which was an indicator of TMD. All patients with TMD have painful coronoid processes when you push on them. So another indicator could be TMD, but again, I felt what I felt without being able to look at it, some exposed bone. She had been through radiation therapy and chemotherapy both, and those were long finished, long completed. Bottom line is, my judgment was at that time that this was not TMD. Her inability to open was not TMD and was caused by either a recurrence of the cancer, or more likely, could be a recurrence, but more likely it was gradual scarring of the surgical areas that were performed 3 years prior. Now, and that is the reason that my associate asked me to see the patient, because he is not an oral or maxillofacial surgeon. He's a general dentist, and he knew that my experience as an oral maxillofacial surgery and doing cancer ablation and cancer reconstruction in and around the face and oral cavity was relatively important, and he was right. So I was able to make that judgment, and my recommendation was you have to go back and see the original cancer surgeon. He is responsible to follow you along, even though you hadn't seen him. And I'm sure it wasn't because they weren't asked to be followed along. So it's a good example, a very obvious example of why it is important to know when you shouldn't treat TMD symptoms. Now, that was a very obvious example, and I use it as an obvious example. There's some other examples that are not so obvious, but you as a treating physician, dentist, whether you be general dentist, orthodontist, or oral or maxillofacial surgeon, just because patients have one or more of the symptoms on the TMD symptom list, frequent or recurring headache, earache, jaw pain, neck pain, tinnitus, ringing in the ears, subjective hearing loss, fullness in the ears, dizziness, vertigo, upper back and shoulder pain and tightness, arm, hand, finger tingling and numbness, and various kinds of jaw locking. Just because they have one or more of those symptoms does not mean they necessarily have TMD. So you have to be able to keep in mind the potential differential diagnosis of these symptoms. On the antithesis, though, of that in the medical community, our problem of the doctors treating TMD is our medical colleagues don't think of TMD in their differential diagnosis when they have patients with frequent or recurring headache, earache, jaw pain, neck pain, ringing in the ears, fullness in the ears, dizziness, upper back and shoulder pain, arm, hand, finger tingling and numbness. If they can't open their mouth, admittedly, they may think this is a jaw joint problem. They might think that. But the other symptoms, going to a PCP, a medical doctor, his first thought is not going to be TMD. But the doctor of dentistry of one kind or another needs to have in his mind a general perception of differential diagnosis so that he does not misdiagnose the problem like our medical colleagues constantly misdiagnose TMD. So I just thought I'd throw out a few discussions, a little bit of discussions about differential diagnosis and the common diseases that can be confused with TMD that actually are not TMD and need to be referred on to the appropriate doctor. One of the other things that I mentioned in previous episodes was my experience talking with a room full of 30 family practitioner MDs. This was a couple years ago, and asked the room their opinion, what they thought they would do if they were presented with a patient with acute and frequent and recurring severe headaches. And I said, what is the first thing that you would do, without giving them a list of options? I just said, what is the first thing that you would do? And basically 90% of the room agreed that the first thing they would do is they would send the patient out looking to get a MRI looking for brain tumors. Now, these are family practitioners, but the first thing they wanted to do was check out the head for brain tumors. And brain tumors are certainly present, but the incidence of brain tumors in comparison to TMD are extremely limited. And sending a patient out for an MRI, you just wasted, $2,000 or $3,000. Where you can examine a patient for TMD, if they have frequent or recurring headaches, all you have to do is put your fingers in the glenoid fossa, have them open widely, push hard, and have them bite rapidly. And if it hurts, the joint's inflamed, you made your diagnosis, almost for sure. It gives an example of why medical doctors misdiagnose this all the time. They're looking for the worst, and they don't think of the simplicity of the number of headaches that are associated with temporomandibular joint disease. But on our side of it, on the dental side of it, you need to be able to be aware that don't think that all headaches are associated with TMD. And sooner or later, somebody's going to walk in your office or walk in another doctor's office with frequent or recurrent headaches that are actually brain tumors. So you want to modulate. The next point I want to make is you want to modulate the symptoms. Now, if For example, if the only symptom the patient has, you run down the symptom list that I've now reeled off twice in this episode, and they only have one symptom, which is headaches, that doesn't mean they have brain tumors. It means you need to be a little suspicious. This might be something else going on if they only have one symptom. On the other hand, and that is the reason you don't accept just the patient's history as to what their symptoms are. You allow the patient to give you their rendition of the symptoms, and you can list them in your mind as they go through. Here's what my symptoms are, doctor. It hurts my jaw every morning when I wake up, and I have headaches constantly, at least 2 or 3 times a week, and I got this neck pain. Well, if you have those 3 symptoms, you're adding to the number of red flags that would lean your differential diagnosis toward TMD. On the other hand, if the patient comes in and they say, I've been having acute headaches for the past month. Have you had headaches that go back any further? No, just the past month. And then you go down the potential symptom list and they have no other symptoms. I, as a double degree oral and maxillofacial surgeon, would be very suspicious that this might be another kind of headache, for example, possibly brain tumor. And if I thought a little further, I would not hesitate sending the patient out for an MRI or sending them back to their PCP or making a referral to a neurosurgeon if I was fairly convinced it might be something like a brain tumor.